Okay, let's talk about high output heart failure. High output heart failure is an uncommon form of heart failure characterized by increase in cardiac output. High output state is due to decrease in the systemic vascular resistance from either vasodilation or arteriovenous shunting. So what do we talk about? We said it is characterized by increase in cardiac output with a high output state due to the fact that you have a decrease in systemic vascular resistance, meaning it's really easy for the heart to push the fluid out, causing increase in cardiac output due to the fact that you have a low SVR, systemic vascular resistance. And why do we have a low SVR? Either due to vasodilation or due to the fact that we have AV shunts, atriovenous shunting. And why this happen? Why do we have all of that? Because of obesity, because of cirrhosis, because of anemia, hyperthyroid, vet beriberi, Paget disease of the bone. All of them could cause decrease in SVR, causing increase in cardiac output, and that can lead to eventually heart failure. It will present as symptoms. It will present with symptoms and signs of pulmonary and systemic venous congestion. So pulmonary and systemic venous congestion will be seen. In other words, pulmonary and systemic venous congestion. So pulmonary edema and peripheral edema would be seen. And let's now look at the more important topic, which is shock. What is shock? The shock is inadequate organ perfusion and delivery of nutrients necessary for normal tissue and cellular function. Initially may be reversible but life-threatening if not treated promptly. Okay, so the whole definition is there's inadequate organ perfusion, meaning you're not perfusing the organs, and you're not delivering the nutrition to the organs. Could be reversible initially, but could be life-threatening if you don't fix it. So what's the types? The types are hypovolemic shock. Okay, hypovolemic shock. What is hypovolemic shock? So hypovolemic shock is basically you have decrease in blood volume, right? And that would lead to abnormal capillary fill. So how do you check somebody has a good volume or not? You look at their capillary refill time. You press on their nail, see what is the refill. So if the blood right away comes back, that's going to be normal. The abnormal is when there's a delay of greater than 2 seconds. Greater than 2 seconds refill time, that will be as if it is known as delayed, and that is decrease in blood volume, and that possibly if the patient could be in hypovolemic. Okay, what is it caused by? Well, decrease in blood volume could be caused by any hemorrhage, dehydration, burns, right? Mechanism, volume depletion we talked about already. Skin will be what? All of these are cold and clammy skin, except the distributed one. Okay, now look at CVP, which is a central venous pressure. PCWP, which is going to be pulmonary capillary wedge pressure, which is on approximate pressure for left atrium. And then you have the cardiac output. Then you have the SVR, systemic vascular resistance, and then we have the SVO2. Okay, so CVP, because you have a low blood volume, right? You have a low blood volume already. So what's going to happen to your, let's say, CVP, central venous pressure? Meaning, what is going to be the pressure in the vena cava? The vena cava pressure is going to be low for sure because you don't even have any blood volume. So that's going to be low. PCWP, because you don't have any blood volume, which is going into the left atrium, you're going to have a low PCWP because nothing is going into the heart. Nothing will go out of the heart. But what's going to happen to SVR? Now, SVR is systemic vascular resistance. Because you are decreased in cardiac output, the sympathetic tone will activate, the RAS will activate. They will cause, what they will cause, we saw before, but they will lead to increase in systemic vascular resistance to vasoconstrictive vessels so that the organs can get the blood, right? So vasoconstriction causes an increase in SVR, systemic vascular resistance will be increased, but the oxygen will be low in the SVO2 is going to be low. Okay, so next one is the cardiogenic shock. With the cardiogenic shock, all you have is the problem is you have left ventricular failure. Okay, why do you have left ventricular failure? The patient could go into maybe the patient had MI that led to left ventricular failure. Heart failure can lead to this. Valvular dysfunction or arrhythmia. All are the causes of left ventricular failure, right? That's the mechanism. Again, the skin is same, cold, clammy skin. Because you have a left ventricular failure, so vena cava, pressure in the vena cava, which is CVP, is going to be high because the fluid, the blood is not going out from the left ventricle. So let's just draw it here. Left ventricle, so right, left atrium. So from okay, let's actually draw the whole thing quickly. So you have vena cavas, inferior vena cava, superior vena cava, right atrium, right ventricle. Then it's going to go to the lungs. From the lungs, it's going to go back to left atrium and left ventricle. From left ventricle, you're going to aorta, right? Because you have stopped the blood flow here, everything will back up. There is more pressure in left atrium, more pressure in the pulmonary, more pressure will go into left ventricle, right atrium, and vena cava. Except that after that, it's not going to be, the blood is not going after left ventricle. So let's see. So you have increased in the CVP, increase in PCWP, decrease in cardiac output because you're not pushing the fluid out. For sure, you're going to have a decrease in cardiac output. Increase in SVR, again, when you have a low cardiac output, the RAS activates, the sympathetic activates, that causes increase in SVR, and SVO2 will be low. Okay, and that will be seen, yeah. Now the next one is obstructive. What is the obstructive problem? The obstructive is you have impeded cardiopulmonary blood flow. So there is an impediment of cardiopulmonary blood flow, right? Which is mentioned right here. Why did this happen? Because of pulmonary embolism, tension pneumothorax, cardiac tamponade. All of them are the causes. So what's going to happen to CVP, which is your vena cava pressure? Well, CVP, okay, now looking at these two things, they have differentiated the cardiac tamponade in a different manner. So we will see how things are working. With pulmonary embolism, tension pneumothorax, CVP increased. Now, CVP increased because the lungs, the fluid is not moving forward from this point onward, right? So the pressure is just going back in the lungs, from the lungs, because of, let's say, pulmonary embolism. In the lung, let's say this is a lung, you have pulmonary embolism here. So the fluid is now moving forward, so it's going to go back. When it goes back, you have increase in venous pressure. CVP will increase. And the pressure moving forward will decrease, so cardiac output decreases. When cardiac output decreases, RAS activates, sympathetic activates, SVR will go high, right? And SVO2 will also be high. Okay, compare this now with the cardiac tamponade. With the tamponade, you have increased in the CVP, but you don't have any problem in the PCWP, meaning there is no problem in the lungs, right? So when you don't have any problem in the lungs or in the left atrium, the PCWP is increased. The problem specifically here is the cardiac, that the cardiac, the whole, there's no contraction. So the cardiac output would decrease. When the cardiac output is decreased, again, same thing. It will activate RAS, activate sympathetic tone, increase in increase in the systemic vascular resistance, SVR, and there will be decrease in SVO2. Okay. And that is going to be all for the obstructive shock. Now the last one is distributive shock. What is distributive shock? It is due to the fact that you have peripheral vasodilation and vaso of venules and arterioles. So peripheral vasodilation of venules and arterioles. So basically, systemic vasodilation is the problem. Why this has happened? It happened because the patient was in sepsis early, or anaphylactic shock. You know, anaphylaxis, anaphylactic shock. That's what we're talking about, or CNS injury. So the first two, anaphylaxis or sepsis, what do we have? And here you would have, the patient would have a warm, dry skin. Important, because of vasodilation, there will be warm, dry skin. Okay. With this, what do we have? We have, because of vasodilation, let's say vasodilation, what did we talk about? We said venules and arterioles, right? So in the venules, meaning all the veins, they're vasodilated, so the pressure is going to be decreased in the CVP, which is vena cava. So when the pressure decreases, it vasodilates, so not much blood is going to go to the lungs. The pressure in the PCWP decreases. But if you look here, the cardiac output is increased here. But with CNS injury, the cardiac output is decreased. Yeah? And why is that? Well, the cardiac output is increased here and decreased there because in sepsis anaphylaxis, the sympathetic gets activated, and that causes the cardiac muscle to contract more, increasing the cardiac output, CO. But this SVR, which is systemic vascular resistance, is decreased because the problem here was systemic vasodilation. And systemic vasodilation is due to the fact that you have, again, as I mentioned, peripheral vasodilation of venules, which are here, and arterioles, which is right here. So due to the fact that you are in sepsis and anaphylaxis, that causes vasodilation throughout, systemic vasodilation, meaning you're looking at arterioles, venules are dilated. Cardiac output is increased because of sympathetic is activating it. Let's just erase some of it. With CNS injury, the cardiac output is also decreased. So if you look here in the CNS injury, everything is decreased. This is decreased because it's a systemic vasodilation, and this is decreased because systemic vasodilation. This is decreased because when you don't push the fluid in the lungs, nothing will go there, and the pressure will be decreased. And same goes here. When there is no blood, there is going to be no cardiac output, and SVR will be decreased because you are causing systemic vasodilation. Okay. SVO2 could be normal or increased. Okay. Okay, now let's look at the sign and symptoms of increase and decrease. So if we if we are increasing the CVP, which is the central venous pressure, that's going to give us JVD, jugular venous distension, hepatomegaly, and lower extremity edema. Where the if you were to increase PCWP, that's going to give us pulmonary edema, cough, orthopnea, and paroxysmal nocturnal dyspnea. Okay. And if you were to decrease the PCWP, what's going to happen is it's going to be a clear lungs. And if you decrease the cardiac output, the signs and symptoms are going to be dyspnea, fatigue, syncope, exertional angina. And that is all for the shock.